Next, we have Dr. Tony Zhang. He is a current stroke fellow here at Methodist. He also completed his neurology residency here at Methodist. He will be staying after his fellowship here in Houston at Houston Methodist Sugar Land, where he will be participating in general neurology and vascular neurology as well. Today, he will be talking about the large core mechanical thrombectomy clinical trials.
Thank you. So today I'll be talking about the large core trials, of which there's been 4 that have been published fairly recently. The first one came out at ISC of 2022, and then the most recent one, it will be in October of 2023, so fairly new data. And I hope to show and convince you that perhaps we should be taking these patients. So first, current guidelines give a level 1A recommendation for patients with acute ischemic stroke with a large vessel occlusion, specifically in the anterior circulation, meaning MCA, ICA distribution, that we should be going for thrombectomy in these patients. And the reason for this is because it's shown to not only improve functional outcome, but it also is a safe therapy. However, this was not always the case. In fact, starting in 1998, people tried to study intraarterial therapies, first with thrombolytics, and then later with various devices. And it wasn't until 2015 that trials first became positive results. In 2015, there were 5 large trials that studied first within the first 6 hours or so with what was known as small core, which was calculated as aspects of 6 or greater. And then in 2018, they extended the time window to 24 hours using a small core, using advanced imaging techniques such as CT perfusion or MR perfusion. In fact, these trials were overwhelmingly positive, almost unexpectedly slow. The number needed to treat was 3, and if you compare that to something like PCI for STEMI, the number needed to treat would be closer to 45. And so part of the reason why there was an expansion to look at large core was because it was such a good therapy. And so why did we avoid these in the first place? So first you need to know a little bit about aspect scoring. So aspect scoring is a 10-point scale using non-contrast CT. There's about 6 cortical areas as well as 4 basal ganglia areas, where 10 is a perfect score. And then for each hypodensity area seen on non-contrast CT, you remove a point. And so the thought process was 6 or greater was small enough core that the risks of reperfusion injury would be low. Furthermore, it was thought that if they had already had an established ischemic stroke, that their functional outcome, regardless of an intervention or not, would not have been good. Then Dawn and Diffuse used the advanced imaging techniques, and they defined in aspects of essentially 50 or greater to be a large core. And so in our trials, we'll be discussing cores with aspects of 3 to 5. Here we see, even from the original paper, that the higher the aspect score, or the lower the aspect score, the worse the outcome. And so we can see as aspect score decreases to 0, we have higher rates of death and dependence. So like I said, we're going to be discussing all of these trials. They had decided to exclude, at least the current published trials, to exclude 0 to 2 because of that risk of increased edema, reperfusion injury, hemorrhagic risk. So the first trial was Rescue Japan Limit. This was published and presented at ISC of 2022. So first, it was a 1-to-1 trial involving 100 patients receiving 200 patients receiving mechanical thrombectomy versus 200 patients receiving medical management. The primary outcome was actually an MRS of 0 to 3. And here we see there was a significant difference in the primary outcome. So 31% of patients achieved an MRS of 0 to 3 compared to 13% in medical management. An MRS of 0 to 3 essentially represents independent ambulation for those who are not familiar. The secondary outcome was what was known as an ordinal shift in MRS. And so if we look at each aspect of MRS, if there was a shift towards better outcome, we see there's more 0s, 1s, and 2s as opposed to 3, 4s, and 5s. And so this was also a significant shift with an odds ratio of about 2.5. Other secondary outcomes they looked at was an MRS of 0 to 2, which is essentially functional independence. And again, although it was not statistically significant, there was a trend towards improvement. So some notable points about this trial compared to the next several trials I'll discuss was that this was a Japanese study, and in Japan they tend to use MRI as the first line imaging modality. And so the aspect score was actually calculated based off MRI with diffusion-weighted imaging, and they had several criteria. They had to say that there was no changes on flare. And so that really limited patients to the acute stroke setting, essentially limiting patients to less than 6 hours, even though they did include patients up to the 24-hour time window. The other thing to note about this study was that because it was conducted in Japan, when they did use thrombolytics, they used that at a lower dose compared to standard US guidelines. So they used that at a dose of 0.6 as opposed to 0.9 mg per kilogram. And so because the study showed an increased risk of ICH, or reperfusion injury, of 58% compared to 31%, there was concern that maybe we didn't see increased bleeding because we were using lower doses of thrombolytics, as well as maybe we didn't see as much bleeding because the time window in which these patients were being evaluated was more in the hyperacute setting. Of note, there was no difference in symptomatic ICH. However, this led to the early release of the next two trials. So in the following year, there are two large other trials. The first one was Angel Aspect, and the second one is Select 2. So Angel Aspect, similar to the Rescue Japan limit, was also an Asian study. In this case, it was conducted in a Chinese population. So we're getting a little bit more broad eligibility criteria. And the inclusion criteria for this one, it was in addition to a non-con CT aspects of 3 to 5, they also used advanced imaging techniques with CT perfusion. And they used a core of 70 to 100 to mimic the aspects of 3 to 5. They also included patients up to the 24-hour window, but in this case, they had more patients compared to Rescue Japan limit. They had about 60% of patients that were in the extended time window, as opposed to about 25% in Rescue Japan limit. This was also a positive study. Interestingly, they decided to, and you'll see the rest of the trials, decided to do ordinal shift as their primary outcome. And again, the ordinal shift towards better outcomes with mechanical thrombectomy compared to medical management. The odds ratio was a little bit weaker compared to Rescue Japan, about 1.5 as opposed to 2.5, but it was still statistically significant. The other outcomes of functional independence, either functional ambulation or functional independence, were also showed an improvement with mechanical thrombectomy compared to medical management. And in this case, they used the higher dose of alteplase, and even then, even though there was more imaging of ICH, in terms of symptomatic ICH, it was not considered significant, but there was a trend towards increased ICH. And so at the same time, the next study, which was Select 2, which is mostly a US trial, but it was thought to be actually an international trial because they include New Zealand, Europe, and Australia. But if you look at it, probably 90% of the sites they enrolled in were the US. They also used similar aspects 3 to 5 as a base, but then they used CT perfusion and they did not have an upper limit. They said any core with more than 50 cc's could be included in this patient population. This, again, was a positive in terms of the MRS ordinal shift. There was an improvement in outcomes across the board, as well as, again, functional independence and independent ambulation. There was an improved effect size with mechanical thrombectomy compared to medical management. Of note, in this trial, for some reason, the rates of bleeding were very, very low, and so the symptomatic ICH levels were only 1% compared to 6% in the previous one. Again, now we're seeing more and more data expanding, first in Asian and now US and international population. And then this leads us to the last one that I'll discuss, which is the tension trial. So the tension trial, compared to the other ones, only used non-contrast CT as an enrollment criteria for aspects 3 to 5. Instead of going up to 24 hours, they went up to 12 hours. And so this was nice because many centers do not have advanced techniques such as CT perfusion or MR perfusion. And so it really opened the world to further ways to include more thrombectomy patients. This trial, again, similar to the other ones, showed an improvement in MRS ordinal shift, as well as increased MRS 0 to 3 and MRS 0 to 2. And just like the other ones, there were no safety concerns. If you looked at the breakdown of ICH, it was very similar. In fact, there was improved mortality, which the other ones could not show. This was then done in a mostly European population. And so now we have data showing basically in Asia, Europe, US, all pointing towards the same sort of data. Lastly, I wanted to talk about a couple future trials that you can expect to see. So the first is LAST, which this trial will enroll patients with aspects of 0 to 2 within less than normal of 7 hours. And so it'll be interesting to see is there an upper limit in terms of how big the core can be and still have improvement? And then the other trial that's already been discussed at a conference, but hasn't been published yet, which was Tesla. And they used aspects of 2 to 5 and only using non-contrast CT, just like tension, except they allowed a last known normal 24 hours. Similar to what Dr. Vahidi was saying, they actually used Bayesian score analysis to calculate superiority. It didn't quite meet there, but it was basically like 95% that it was going to be superior. But there was a strong trend towards benefit. And if you just did it based off of the 0.05 criteria, MRS of 0 to 3 and safety had improved outcomes with mechanical thrombectomy compared to medical management. And so in terms of the overall take-home points, I would say good outcomes with endovascular therapy is lower in those with large core populations compared to the small core populations, but there's still improved outcomes of improving functional and independent ambulatory patients. Hemorrhage rates post-endovascular thrombectomy in this population tended to trend higher, but symptomatic hemorrhage does not seem to be statistically different in these populations. And then lastly, non-contrast CT with CTA seems to be a promising alternative to advanced imaging techniques such as CTP or MRI in the selection of patients with ELVO in the late time window or large cores.